Thank you, Dr. Nathan. So I'm going to be presenting the case about limb ischemia as a complication of VA-ECMO. So this was a 60-year-old male who was admitted for a high-risk PCI from an outside hospital following a non-STEMI. He's got a history of coronary artery disease with a CABG in 2013. Other significant history consists of PVD. He's had bilateral lower extremity angioplasty with stent placement a few years prior, and he's also a smoker. So the patient presented with a non-STEMI at an outside hospital. He was treated medically at that point and was discharged. His left heart cath had revealed diffuse native coronary disease, which was significant for an 80% proximal LAD lesion, as well as occluded bypass grafts. The patient began to develop worsening shortness of breath. He had an echo done, which showed an EF of about 40 to 45%, which was down from his baseline. And he also underwent a cardiac MRI, which did show viable myocardium in the LAD territory. So the plan was to transfer him to our center for a high-risk PCI of the LAD. So the PCI was complicated by PEA and VFib arrest during stent deployment due to an LAD dissection. Our team was then called at this point to place the patient on VA-ECMO. A right femoral artery cannula was placed, a 17 French, and a left femoral vein cannula was placed. We attempted at that point in the cath lab to place a distal perfusion catheter, but were unsuccessful due to an occlusion of the right SFA. After he was placed on ECMO and was supported, a left femoral artery sheath was placed, and additional stents were placed in the LAD due to the dissection. He was started on bivalirudin at this point and was also maintained on dopamine at 2.5 mics per kilo per minute. So I don't have actual angiogram images to show the severity of his PVD. These are done with the sheath in place, but this is the right leg, and you can see above the bifurcation, it's very stenosed. And this was the side that the cannula was inserted on, and we were unable to place the antegrade. And this is the left, which shows, nothing really distally past the sheath. So the patient was sent to the ICU after this, and he was noted to have bilateral cold limbs. He had mottling, and he didn't have any distal pulses to his lower extremities. CV surgery was then consulted immediately, and the plan was to take the patient to the operating room to potentially decannulate ECMO at this point. But unfortunately, he didn't tolerate decannulation due to severe MR and hypotension. So then the decision was made to place an arterial cannula in the right axillary in order to remove the right femoral artery cannula that was compromising flow to his leg. A thrombectomy was done at this point. And following the procedure, the perfusion to his right leg did improve. The color improved, temperature improved, and he had distal pulses. Unfortunately, he did develop left leg ischemia during the hospital stay, which resulted in amputation. As we can go back, he had a sheath placed in the left femoral artery, and a thrombus was formed there. We didn't have any further issues with the right lower extremity, and no issues with the right upper extremity where the axillary cannula was placed. We continued to try and wean him off of VA-ECMO support, but were unsuccessful. We had issues with anticoagulation due to bleeding from the amputation site, so he wasn't therapeutic with heparin until about post-op day 4. On post-op day 3, he had some pupillary changes, which prompted a CT of the head to be done, which revealed a left MCA infarct. He had a follow-up CT done several days later, which did show new infarcts with herniation. And ultimately, the family made the decision to withdraw care. So for some discussion about limb ischemia following VA-ECMO, it occurs in anywhere between 10 and 30% of patients. I've seen numbers up to 70% following ECMO. It obviously increases mortality and diminishes the quality of life. Risk factors include, obviously, patients like this that had severe peripheral artery disease, diabetes, a younger age, which is typically due to lack of collateral flow, and pulmonary disease. There are measures that we take to reduce the incidence of limb ischemia after VA-ECMO insertion, which include the placement of distal perfusion catheters. Obviously, severe PVD can complicate the placement of an antegrade catheter, making this difficult. Cannula size is also an issue. Obviously, the larger cannula you place, the lack of distal blood flow. There's also evidence to show that same-side cannulation, as far as the arterial and venous, can compromise flow. There are alternative cannulation strategies like we used in this case, such as axillary cannulation or central cannulation in patients that do develop limb ischemia. And full anticoagulation is also important, but that was also a challenge with this case. So this is a picture of our technique that we use to place the distal perfusion catheters. We use typically a 6 to 8 French sheath that's placed in the SFA to provide distal blood flow to the leg, and it's connected to the arterial cannula. At the bedside, if we place VA-ECMO, we use ultrasound and a micropuncture to obtain access. We have our surgeons readily available if we're not able to obtain percutaneous access and can do an open access. And this is the axillary artery cannulation. In this patient, a 10-millimeter graft was sewn to the right axillary artery and then is connected to the arterial circuit and sewn into place, and maybe after our surgeons can add some details about that. So overall discussion, you want to avoid being put in this situation. This patient was arresting on the cath lab table and we were called, so the benefit of saving his life obviously outweighs the risk of knowing that he has PVD. But you want to know the severity of the PVD prior to doing a PCI in case you need to have a backup plan. And also the use of Impella or PVAD support during the procedure. Perhaps this patient wouldn't have arrested and required VA-ECMO had he had the PCI done under Impella support. And then what do you do if limb ischemia does occur? You obviously want to involve cardiovascular surgery or vascular surgery early to have them help as far as salvage techniques or alternative cannulation. And then it's important also to remember to discuss with the patient prior to performing PCIs in these patients that are at a very high risk of developing limb loss, that it is a complication. It's a devastating complication that can result in a loss of quality of life. And some patients may decide not to proceed with the PCI if they believe that this is a risk. Thank you.
It's an interesting case. I think almost everybody in this room now is probably doing some type of distal cannulation at this point because we recognize that, in fact, you more than likely you're going to wind up with limb ischemia if you don't. Sometimes what we'll do if we really suspect high PVDs, we'll actually Doppler the lower extremity to see if we can actually get a Dopplerable pulse. Do you all ever use either through percutaneous or through vascular surgery, DP, or or a posterior tibial approach and do a retrograde stick?
We have not that I'm aware.
Question. Just I want to ask the panel and the teams here. One, NIRS, the use of near-infrared spectroscopy to go ahead and measure some distal flow. How's that going, and have you been fooled by it? Because clinically, nothing beats a clinician, not even NIRS. Sounds fancy, but it doesn't. And the second question is, if you have a case of severe limb ischemia, you do everything to correct it. Have you seen a lot of multi-system organ failure with a vasoplegic state following that? Because it's not describable. We've seen it, and we put the patient on antibiotics, but I think it's the necrosis and ensuing. But I want to hear about what people's experience is.
I say when you've seen it, usually it's catastrophic. It's awful because it's usually not seen so quickly. Usually by the time somebody calls you, it's oftentimes a bit delayed. I guess the question I would have for you though is this patient was already very compromised and on many days. How do you approach after day 2, day 3, this patient's already really not going to go anywhere, and then has a stroke on day 7 and finally gets turned off on day 10. Might be somebody that unfortunately the game, you tried your best, but the things were somewhat lost even earlier. And we've tried, having made mistakes, to try to shorten that and not push that many days. Try to, if we can't succeed, then try to encourage families to withdraw care sooner.
In really severe limb ischemia, I think in the necrotic situation that impacting all entire physiology, I think getting rid of that limb is early is really important.
I have a question for the panelist. We have noticed when you have VA-ECMO with the venous side and the arterial side in the same, it's not limb ischemia only from arterial hypoperfusion. There can be edema and lack of venous return. And second is people with significant third spacing with severe edema can have extensive compression. So are there any thoughts of splitting and putting the venous side one side and arterial side the other side to minimize this?
Where is Ali? He should be the first person to be talking. There he is.
But it's not always the case that you will be able to have that luxury to split. Sometimes you have a villa on one side and you don't have the options to select. But what we're doing is the antegrade cannula in almost every case, except if it's under cardiac compression. If it's under cardiac compression, we're doing the big cannula first and then thinking about the antegrade later on. But in every case, we try to get the wire in an antegrade way before I'm going to get the big cannula. So if we have that, the rates of lower limb ischemia is really very, very rare, and our data is published in January 2019 Annals of Thoracic Surgery. Our rates of lower limb ischemia with that approach is probably 1 case out of 180 cases we have related to the ECMO. We have lower limb ischemia related to the high doses of pressors the patients were on before we placed them in ECMO. Even we place them in ECMO, we have patients which was black fingers, not only toes, fingers, because of the high doses of inotropes they were on.
I think that either works. I think if you have the luxury of actually time, always getting that antegrade cannulation first is ideal, especially related to bleeding complications, which we didn't mention. And we use a wired sheath, because I think sometimes what happens is that you actually have it in the right spot, and then it winds up getting kinked if the patient's body habit is not receptive to that. Yep. So we typically use a 6, and I don't think it must have been said during the presentation sometime in the last 3 days. If you have the time as well, a peripheral angiogram, just a single shot, gives you a lot of information. The other alternative thing to do is if you really had somebody who is really bad. We did talk significantly about it's the venous return that's going to provide a lot of your flow. So you can, if you have a peripheral angiogram, you can downsize your arterial cannula to see if you can get some blood to slip past it.
I think one of the important points is, as we have been saying during this symposium, timing. I have to congratulate Amanda, our nurse practitioner, and our nurses, because they pick up really quick these issues the majority of the time. Actually, last thrombectomy this week, I was walking in the unit and the nurse just brought me to the room and said, I'm concerned about this patient. Immediately we examined the patient, got the arterial duplex study, took it to the OR, did thrombectomy, the patient is fine. If you get to the point that multi-organ failure is because there's so much breakdown of the myocyte and the kidneys start failing and everything. So it's about timing. I always said, when Amanda is on call overnight and she called me, it's the only woman that called me that I run, because when she calls, I put my scrub and start driving because something is wrong.
Okay. Thank you very much. I think for this great presentation.